Good morning. My name is Barbara Revel. I'm the Fellowship Director for the Nurse Practitioner Palliative Care Fellowship at Dana-Farber, which is part of the Harvard Interprofessional Fellowship. And I'm very proud to introduce Kate Sciacca, who is a nurse practitioner in the Harvard Interprofessional Fellowship this year. She received her Bachelor of Arts degree at the University of Denver and studied in biology and international studies. She moved to Boston in 2012 and studied at Northeastern University, receiving both her Bachelor of Science in Nursing and her Master's of Science in Nursing. She also worked as a graduate student, both as a teaching assistant at Northeastern and volunteered at a elder wellness and health education program here in the Boston area on topics ranging from end of life to nutrition and depression. She worked at Brigham and Women's Hospital as a registered nurse on the integrative teaching unit for 4 years before being accepted into a fellowship in 2018. And she will continue her work as a palliative care specialist in July as a nurse practitioner on a newly created embedded palliative care team for advanced kidney disease at Brigham and Women's Hospital. So happy to meet her. She'll be talking about I Can't See From Here, exploring the intersection of nursing theory and palliative care.
So as Barbara said, my name is Kate Sciacca. I am a nurse practitioner fellow over at Dana-Farber and Brigham and Women's, and I will be talking today on a topic entitled I Can't See From Here, exploring the intersection of nursing theory and palliative medicine. So a few housekeeping details. I have no financial disclosures. The objectives of this course are to identify common situational causes of nursing concern in palliative care patients, describe the prevalence and consequences of provider distress, and apply the wounded healer theory to both palliative care providers and the bedside nurse. A couple of what my objectives are not. So I do not intend that by the end of this you will be able to recite nice phrases to say to nurses. I don't want you to be able to, well, I do, but I don't want you to be able to ease the tension with nurses or explain why you should be nice to nurses. A couple personal disclaimers. I am a nurse and a palliative care clinician. So over the past months, I've had a pretty incredible journey of June 26th of last year, I was a bedside nurse on a chaotic general medicine floor. And then I took a few days off, did my laundry, and showed up on July 2nd as a palliative care provider. I really did. Again and again throughout the year, I've been struck by the total disconnect between what I thought that palliative care clinicians did and what they actually did. I really feel like I had no idea. I was also struck by kind of how nursing and palliative medicine are operating in such different silos, but caring for the same patient. The title of today's presentation is I Can't See From Here, because that's the way that I felt over the past year. I felt like when I was a bedside nurse, I couldn't really understand the perspective of a palliative care provider. And then being a palliative care provider, I'm starting to lose the perspective of what it was like to be a bedside nurse. And I feel that in both roles, I couldn't quite see what everybody did. The most shocking thing to me was the realization that some of the cases that have really wounded me as a bedside nurse could have been so easily prevented by providers. In an effort to highlight the ways in which these wounds have been impacted on me as a bedside nurse, I'm going to talk about 3 cases today. They're not cases that I've talked about publicly or privately, for that matter, so this felt like the right time. So I hope in speaking with you about these cases that they help you to gain a different perspective about some of the experiences of bedside nursing and help you see how your impact as a palliative care provider changes that dynamic. So we'll start with explaining what the wounded healer theory is. So I have chosen these 4 kind of figures throughout history to really describe to you how this wounded healer theory started and then how it was developed and applied to nursing. So we'll start with the legend of Chiron. So Chiron was a Greek god. He was friends with Hercules. However, they got in kind of a disagreement one day and Hercules stabbed him with an arrow that was coated in another Greek god's blood. So being a Greek god, he's already immortal, and now he has these wounds that will never heal because of the coating of the arrows. So you have wounds that never heal that are incredibly painful, and now you can't die. So it's a tough situation for him to be in. So he takes himself out of the game and kind of goes into a cave for an extended period of time. And the different Greek gods throughout history send people to him in order to learn how to heal people and learn his wisdom. One of the people that was sent to him was Asclepius. You might know him. It's the Greek god of medicine. So he taught the Greek god of medicine about medicine. So this is really the first figure that we have that describes this wounded healer. Then Plato came along and said that the most skilled physicians themselves suffer from every disease and are not by nature very healthy. He said that I do not think that they treat the body with the body, but rather the body with the soul, which cannot treat anything if it is or has been bad. In the 1950s, the psychologist Carl Jung really applied this to the modern day practitioner. So he said that the doctor is effective only when himself is affected. Only the wounded physician heals, but when the doctor wears his personality like a coat of armor, he has no effect. For only what he can put right in himself can he hope to put right in the patient. And it is his own hurt that gives him the measure of his power to heal. So he was really the first one to take this wounded healer concept and apply it to modern medicine. Then in 2012, Maren Conti O'Hare applied this theory to nursing in her book, The Nurse as a Wounded Healer from Trauma to Transcendence. So she said that caring, compassion, and empathy are the basic components of nursing, that nursing roots have been wounded by the healthcare system. So I was reading a book on the genesis of nursing, and it was talking about how that Mass General started nursing, and it was talking about how the nurses here were kind of the dogs of the hospital, and nobody wanted that job. So nursing really started in a place where it wasn't a job that anybody was particularly excited about. Florence Nightingale maybe was, but other than that. So she talks about how there's this path from wounding to trauma to transcendence to then applying those principles to become a healer. And she provides many fictional and factual examples of nurses throughout time that have done this. So you can see here, there are other people, in literature that do describe this wounded healer theory, but these are kind of the four that I've chosen to highlight how this theory was started and then how it is applied to nursing. So there are some facts about nursing that as an audience we have to accept as true in order to move forward with this discussion. Nurses are forced to witness perhaps powerlessly catastrophic events. They physically work with the dead. So when you start orientation, you're taught how to do postmortem care. You're taught how to tie bodies in a way so that they'll stay in the body bags. You have to put them in, you have to take their clothes off, you have to take the Foley out, you have to take the drains out. And you have to do this in a certain way so that the morgue is pleased with you. So you learn how to care for dead bodies. You then take them down to the morgue. Eventually the transport person leaves and you're in this fridge trying to figure out how to log people's names in. And then you go back to the floor and you walk into the next room and you have to deal with the woman who's really upset because she got, I can't believe it's not butter and not a genuine butter patty. No traumatic event is ever wholly overcome by anyone. Societal recognition of the etiology and long-term effects of nursing distress and trauma are underdeveloped, perhaps because it's insidious, subtle, and unpalatable. Even nurses turn away from this topic. We are the worst patients with doctors, and we don't like to talk about these traumatic events or that they've ever happened. When providers are unwell, the quality of care is worse. We know this as palliative care clinicians. We talk a lot about this, how we have to be well in order to help others, but this is critical in nursing as well, because you really can't go into a room and provide compassionate care if there's something stopping you. So the first case that I will discuss is a case that occurred in March of 2013. I was working from 7 a.m. to 7 p.m. and I had a patient. She was a 37-year-old female. She had a history of breast cancer, which had been in remission for several years. And she came into the ED with abdominal pain, nausea, vomiting, and back pain. She was married and had 2 young children. So she was admitted overnight at 2 o'clock in the morning and told that there was something irregular on her CAT scan that needed to be worked up and warranted admission. I came in at 7 a.m. and took a report on the patient. Now, as part of the nursing role, when there's a new lab result and a notification comes up in Epic, so you actually see it come up, every interpretation, every lab result, every piece of data that's collected by Epic flags, and you have to go into the chart and time mark that you saw it, and you acknowledge it, and you notified the right people. So in that way, you're constantly looking at new lab results, and it's an expectation of the nursing role that you do that as soon as possible. That's why if you've ever covered overnight or any time as a clinician, you get so many pages about lab results, because that's part of the nursing role. So in this way, you're continuously looking at results. And before I went into the patient and met her that morning, I'd already reviewed everything, including her CAT scan, and I knew that she had widely metastatic disease. It was everywhere. It was in her bones, it was in her liver, her spine, and my recollection was that there weren't very many places it wasn't. Now, I won't boast to be a radiologist or an oncologist, but I knew that this was really bad. The team wanted to round and collect more data so that they would be able to present her with the whole story that afternoon. I took care of her for the next 10 hours, helped her eat, helped her shower, helped her use the bathroom, and washed her hair. And the whole time she was asking me, I don't know why this is taking so long. Do you know what's happening? Can you tell me what the test results said? Do you know when somebody's coming? Why am I having this pain? And the doctors were still compiling data. What does this do to a person, right? To have to lie and to have to smile and to have to provide compassionate care while you know that the person that you're caring for, that you're physically touching, is ridden with cancer, and you know the reason why, but you can't say anything. I know that you're all thinking, oh, just go get somebody, bring them back and have them come tell her. But if we did that for everybody and every new result that came in, nothing would get done. We don't live in a world where time is in surplus. Knowing the results of a test and having to deny that you know them is something that happens every day to nursing. And it triggers a sense of anxiety and stress every time. So nurses have very high levels of stress. They have the highest levels of stress in healthcare. It's linked to poor nutrition, smoking, alcohol, and drug abuse. They work long hours, have disproportionate levels of skill, and often work in unsupported work environments. So the American Nurses Association, which is kind of the largest body of nursing, did a survey in 2012 and showed that acute on chronic effects of stress were the top health and safety concern for nurses. And this data is consistent with that of a survey done in the early 2000s. So it really hasn't changed that nurses are ranking this as a top safety concern. More shockingly is that 30 to 50% of new nurses either change positions or leave nursing within the first 3 years. I think if you were talking about any field and you were starting out and you were going to school and somebody told you, hey, but 30 to 50% of you guys who are in this class won't actually do this job or will change jobs, I think no one here would logically choose that, but we do. They also have incredibly high rates of anxiety. So one study looking at 120 ER, ICU, and general medicine nurses used the Beck anxiety inventory and showed that all scores were in severe range. They made highly significant correlations between anxiety, rates of depression, disassociation, and PTSD symptoms. Some of the causes for anxiety that these researchers found was frequent traumatic experiences, lack of control, patients sharing death realizations with the nurse and not their family in order to try to protect the family from what they were realizing, an inability to cure. Interestingly, they didn't find that these rates decreased over time at all. So it didn't matter if a nurse was there for 30 years or had been in practice for 3 years, the rates of anxiety were the same, which really goes to speak to how you don't turn seasoned over time. You still have this anxiety. Whether it manifests differently or not is a different story. So this brings me to my second case. So this was a case that occurred in July of 2017. I was on from 7 p.m. to 7 a.m. and was taking care of a 67-year-old female with advanced dermal and systemic sclerosis involving her skin, heart, multiple organs. She also had diabetes and other comorbidities. She came into the ED with shortness of breath and had around a 3-week admission, for which we were constantly watching the telemetry because she would go trigeminy and trigeminy and PVCs, and you would just sit there and watch it and watch it and watch it and watch it march out overnight. I picked her up at 7 p.m. I knew this patient pretty well, and I went into her room and stood in the room and was documenting and waiting for her nebulizer to finish in order to give her her nighttime meds. I noticed the tele alarm went off and looked up right in time to see her eyes roll back in her head and her body go limp. So I yelled for help, went and got the backboard, started compressions, and did 2 cycles before the code team arrived. We continued to code this woman, and as it often happens, about 10 minutes in, somebody looked up and said, "Has anybody called this woman's family?" So somebody ran and called the husband, who said that they never had a conversation about this. So he said we should keep going because they never talked about it. He didn't know what she would have wanted. So we did for another 30 to 40 minutes, to the point where her ribs could be felt to crack, and we stopped seeing her chest expand in response to the ambu bag. It then became my role to insert needles into her intercostal space to try to reinflate her lungs. For months after this happened, I would wake up breathless at night and picture the blood smeared onto my goggles and not be able to take them off. I still remember exactly how it felt to push the needle through this woman's sclerotic skin. I think that so often in palliative care and in other fields, we think that code status is a discussion better left till tomorrow when you've had a really hard goals of care conversation. Sometimes there's not a tomorrow. I know that not all of you might agree with code statuses, but it doesn't totally matter. It's the world that we live in. And when somebody's eyes are rolling back in their head, you don't have enough time to look at their last documented serious illness conversation. Although maybe someday. I know you're working on it. So rates of PTSD in nursing are incredibly high. So in the community, at any given moment, the rate is about 3.5% with a 6.8% lifetime prevalence. In nursing, these 2 studies looked at adult nurses and pediatric nurses and found that 22 and 21% respectively had PTSD symptoms at any given time, and 71 and 75 of those experienced these symptoms for greater than 3 months. So this just kind of goes to show you it's largely much higher than the general population. This is a graph showing the percentage of hospital providers at risk for PTSD development. So they looked at different disciplines within the hospital, and you can see that the ED nurse and the ICU nurse and there's the ED resident and attending also have very high rates of risk. And you know, what I'm talking about today is nursing statistics, but that doesn't mean that it can't be applied to other disciplines. Despite these really high levels of PTSD, there is no data on nursing suicide currently. So there was multiple studies done, one in the 30s to the 50s, that said that in Tulsa, the percentage was 6 times higher than the general population. In 1997, a study came out that said that it was in the top 5 causes of death for female nurses. And in the 80s, in England and Wales, they said that it was the occupational group with the largest proportion of female suicides. This was a literature review that was a very robust review, and it was published last year, and just really goes to show that there's just no data in this area. You can see positions at the top and different public service providers. So this brings me to my final case. This was in December of 2015. I was working from 7 a.m. to 7 p.m. It was my 3rd shift in a row. And I had a patient, he was 98 years old. He had advanced dementia, hyperlipidemia, and hypertension. He came into the ED because his hypertension was very poorly controlled. Over the 3 days that I cared for him, he became increasingly agitated and aggressive, always typically when we were trying to take his blood pressure, which, as you can imagine, we were trying to do quite frequently. Several times it got so bad that he would run into the hall, become physically at risk for himself or others. We'd have to call security to come to the floor, and we'd take him back into his room and administer IM Haldol. It was my job as the nurse to help hold him down and to give the injection. On the 3rd day that I had him, I did some chart digging and found out that he was a Holocaust survivor, and that he had been in an internment camp, and had been diagnosed with PTSD in the past. This was the reason that he couldn't tolerate ever having his blood pressure taken. I've thought about this case and this guy countless times over the past years. I'd taken a few days off after this happened, and when I came back, nobody really knew where he went or what happened. I've always assumed he went to one rehab or the other, and which is probably true. But if anyone said and knew, they didn't say anything. I felt overwhelmingly guilty about this and what I had done and my acts of physically holding this man down. And I still carry a certain amount of moral distress with me. We've talked a few times in this Ether Dome this year and in fellowship about what it means to suffer with and what that does. So in nursing, that means that to some extent, we're simultaneously experiencing the patient's suffering from both our own standpoint and from that of a patient. It's this phenomenon of suffering with that makes nurses vulnerable. I know that in palliative care, we do a lot of talking about what it means to sit with suffering, and I think that's fabulous. But I wonder what the difference is between sitting with suffering and actually physically being the one to hold somebody down, and if that's a different degree of suffering with. Nursing distress has a very long definition. It's occupational, organizational, relational, emotional, personal, moral, spiritual, and ethical dimensions of stress that interfere with your ability to professionally be responsible. So not only do you have this level of distress, but it also impacts the way that your job is operating. Nursing distress levels are pretty distressing. So in 2016, there was a study of 163 oncology nurses. You can see here the nurse's average score was an 8.06, and the patient cutoff using this distress thermometer, which is the indicator that they used in the study, was at 4. They would say that they had moderate to severe distress, and they would be referred to a mental health provider for for more evaluation. So this just goes to show you the nursing rates are double, yet in 43% of the time, the nurses didn't report that they had any institutional assistance. Moral distress decreases quality of care. So it decreases the time spent with the patient and the family. It's related to job retention and job satisfaction, and it's a significant predictor of burnout. So in this study, they looked at reasons for why nurses left nursing, and 25% of the time they indicated moral distress as the top reason that they'd left their jobs. It's cumulative over time. It increases while meaning in work decreases. It's a long-term issue similar to anxiety and stress that we looked at before. So these things are not going away. They don't get better over time. It doesn't get easier. This is just the definition of moral distress, is when one knows the right action to take but is constricted from doing so. So what's happening? Why are all these things occurring? So these are the three research studies that have shown the maybe indications for why the causes behind PTSD and nursing distress. So the first one is experiences leading to PTSD, not being able to save the patients, seeing patients die, performing medically futile care. The next study looking at the reasons for PTSD symptoms to be triggered by the trauma of others were exposure to end of life, death, cumulative exposure to patient suffering. And then the last one, looking at causes of moral distress in the ED, looked at extensive life-saving actions prolonging death, not enough information being provided to patients, and participating in care of the hopelessly ill patient. Do you notice anything? Sounds like thanks, Rachel. So these are our patients, right? This is our patient population. This is who we work with. These are the people that we're trying to work with. Going backwards. So that brings me to why palliative care. Why am I discussing this today to this audience? I would argue that the impact of palliative care on nursing distress is twofold. Initially, it decreases the opportunity for nursing trauma. And secondarily, it promotes wounded healers. So let's look at number one, so decreasing opportunity. So I would argue, and this is a gross oversimplification of what palliative care is, But I would argue that the primary objective is primarily to decrease patient suffering. I don't think anybody would have a problem with that. But the secondary outcome is that we decrease the amount of events that can trigger nursing distress. So these were our patients. So if you look at this kind of figure, I would argue that we have medical care, for those of you across town, over here. And then we have the patient's goals here. Without palliative care, we're providing a great deal of nursing care that's happening in that space that might not be aligned with the patient's goals. So you're doing things like labs, procedures, holding people down, doing CPR. That all happens here. I think that with palliative care, you have, that gets shortened. There's not as many things that you're providing that happen that are in line with medical goals, but not in line with patients' goals. I think the number of nursing interventions that you're providing that aren't in line decreases. So there's not that much good data on this topic, but there is some coming from nurses' experiences taking care of patients that are dying. So the themes that these researchers found about end-of-life nursing is that nurses were able to suffer with patients and encounter their true selves. They could be authentic, forming new attitudes and states of minds consisting of courage, calmness, and passion. It was self-illuminating. The benefits of end-of-life care were mutual, and nurses expressed gratitude for providing this kind of care. There's also some literature on hospice nursing that shows that hospice and oncology nurses, as years increased, they increased self-transcendence, burnout decreased, emotional exhaustion and depolarization decreased. And this is directly opposed to all of the data that we saw before on nursing distress and stress. So I think that in this population, there is possibly something happening where providing care that's more in line with patients' goals is actually beneficial to nursing. So the second one, promoting wounded healers. So transcendence in this model of the wounded healer is pivotal. So without the transcendence and without using the wounds that were inflicted upon you to be able to kind of come to terms with that and then incorporate it into your care, you have to find a way to transcend this. So I was looking around in the literature about the best way to describe this when it comes to medicine and when it comes to palliative care. And with Dr. Lally's permission, I'd like to share a quote from her recent JAMA publication. She was discussing her experience with breast cancer and how she was afraid in some way that it would subtract from the care that she was able to provide to her patients. And she didn't find that. She found that indeed a newfound sense of empathy rather than sympathy now informs her work and strengthens her connection with patients. I've noticed one concrete change in my practice and teaching. Having experienced my fair share of denial, I am attuned to its protective power. So this just is one example of how somebody was able to use their own experience and it was elevated their practice. So what does transcendence look like for bedside nursing? It looks like accepting that nursing is a wounded workforce, which is kind of a large pill to swallow. It means to recognize and heal your own wounds in order to assist others in their own healing. It means to place value on the wounds that have been inflicted upon you. And it means to expand the concept of PTSD outside of the negative diagnostic label. This is reinforced by what we know about nursing. So we know that nursing, we'll get there. We know that nurses have compassion satisfaction, positive feelings derived from helping others through traumatic events. We know that the sense of worth is described as one of the most rewarding parts of nursing and why a lot of nurses do what they do. And we know that when you have increased meaning in your work and as a nurse, it's protective. It protects you against things like burnout, and anxiety, and distress. I think that you'll find this is true for a lot of nurses and for a lot of palliative care providers and for a lot of everybody. If you believe in what you're doing and if you want to do it, then it changes the way that you work for your lifetime. So you might now be asking yourself, when are we supposed to do this? So this was a figure that was created that shows how nurses can go from a place of possibly PTSD development after a trauma, or go through to the wounded healer, down to self-healing, transformation, transcendence, and then the consequence being able to use their therapeutic self. So this kind of describes the path of either PTSD or the wounded healer path. I would argue that palliative care impacts this here by, as we said before, by just decreasing the amount of times that this trauma occurs. I also think that it impacts here and here and here and here and here. I think that what we do as palliative care providers and the communication skills that you're already using and the way that you're interacting with the patients and the staff is already impacting the development of this pathway. I can say that because it's happened to me. So, in conclusion, I hope that you understand that palliative care is already doing this work. I think that so often we learn about things that will promote us to do things better or do things differently or have a change in our practice. And I want you to know that I think that this is something that palliative care is already providing. I hope that you have different implications on your practice and what the implications are of what you do as a palliative care provider. I hope that you can consider palliative care's impact on a larger scale, outside of just the relationship with the patient, your relationship with your colleagues. I hope that you can consider this your relationship with the patient and the nurse and the healthcare system as a whole and what happens to that system. I hope that you can let this add value to the work that you do. I hope that you can promote nursing as wounded healers. I have been incredibly lucky over this past year to have worked with some amazing mentors and co-fellows and everybody that I've worked with that's helped me to take the wounds that have been inflicted on me and to turn them into things that are an asset to my practice. And I thank you all for that. The end. I guess now we do questions.
Thank you, Kate.
Do I have to do anything? No, repeat. Oh.
Thank you very much, Kate. Sharon Levine from Geriatrics. Your third case is our lives all the time. So this begs a question. In education for medical students and often in residency programs, there are reflection rounds to help people to deal with these kinds of things. I mean, one of the things that you talked about, which is really very true, is that one of the reasons I'm a geriatrician is because I love my interprofessional colleagues, especially nurses, and how much muck and fluid and everything they deal with is really sort of amazing to me. But I wonder if this has been incorporated, the reflection and talking about this into nursing education, either at the basic level or at advanced practice level.
So I can speak to my own experience. So everybody heard it, right? So I don't have to say it again. Okay. I can speak to my own experience in that I think it was incorporated at the very start, but I wasn't in the weeds enough to know why I was being taught it. So I think that it does get wrapped into nursing school, but it's just too early for nurses to really kind of know what's happening enough. Like we had a mindfulness class. I was like, oh, this is great. Like, but I didn't know why I needed to be mindful, you know? So I think it kind of is something that needs to be incorporated later in nursing practice instead of in school, although probably valuable in educational programs as well.
Kate, that was amazing. I just thought of an image as you were talking about the wounded healer in Japanese culture. When pottery breaks, often they fill the scars in with gold, and it's and sort of thinking about how we all have scars and sort of to celebrate them. And I sort of think of that image as the new form of beauty that we in our nursing careers have, been able to establish. So it was beautiful. Thank you.
Thank you, Kate. That was really fantastic. One of the things that struck me when I was looking at prognostic models in heart failure is when you come up with computer models. Computer models are better than physicians in predicting prognosis. but they're not better than nurses, a bedside nurse predicting prognosis. And it made me think about all the things that a bedside nurse sees during a day that helps them to formulate some kind of prognostic picture, and made me wonder about our training. And I wonder if you can speak to, having been in an interprofessional fellowship, are there things that you think if other residencies and fellowships were interprofessional, ways that this might be better?
Yeah, I mean, I've learned a lot from being in this fellowship and being with physicians at the same time, and I will infer on them that they've learned a lot from being with me. I can say that. You've said it. So I do think, like, I think you can't understand a different role until you have somebody that you're close with that's done that role. And I don't know about how the easiest way to do that is, but I think just spending time with people and just listening to different people's perspectives is the most important thing. When I was a nurse, we had medical students shadow us for the day. So as part of the teaching program, they came with us and were with us for 12 hours. And they were always like, by the end of the day, like, and I knew that it impacted them in a way. So I think if something like that, like some model like that, where you get to actually see the role is like, would go a long ways.
I have a question. Wonderful job, Kate. You said that this is one of the objectives is not to learn about nice things to say to nurses. I wouldn't discourage people from doing that.
I wouldn't either.
However, I wonder if there's a way that we as palliative care providers can tune into the wounds that may be in the process of forming, and if there's a way to kind of, I guess, get a sense of that when we're talking to a nurse at the bedside.
Yeah. I think that my hope for this talk, and why I said not to recite phrases, is that I hope that you get a different perspective for why somebody might run down the hall and say, did you talk about code status? They can't be a full code. Like, and I know as palliative care providers, we're like, oh my God, I know, like, but like that's coming from somewhere, right? So I would just encourage everybody to know that the nurse might be in some place in that pathway from trauma to kind of being a wounded healer, and you never know where somebody's at when you're talking with them. And I think a lot of what we learn as palliative care providers and the communication skills, it's ingrained, and I think just using those skills to talk with the nurses as well.
Any other questions here? Oh.
Thanks, Kate. That was awesome. Thinking about your title and intro when you said, I cannot see from here, and how when you were a nurse, you couldn't truly picture what it would be like to be a palliative care provider, and now vice versa, as a palliative care provider, it's getting harder to hold on to those things that made you a nurse. How do you anticipate kind of maintaining that nursing identity going forward? And I guess, where do you stand? Can you see now from here, or yeah?
I think I can see now a little bit more. As most of you know, I've still been working as a bedside nurse at the Brigham for 4 shifts a month. So I kind of use that to ground myself back in it. I don't know if I stop doing that, how I will keep that. I think it's just remembering the cases that I've had and trying to remind myself of that perspective. But it is hard. And as you move into a different role, and I think at the start of fellowship, I really thought like, okay, I had to like push that aside, and that was like not my job anymore. And now I have to do this job, and learning how to kind of incorporate those two things. I don't know in a good way too, though.
Nancy?
Kate, that was a fabulous talk. And having been a nurse for greater than 30 years and a palliative care nurse practitioner for over a dozen years, you stirred up a lot of stuff that, like you said, people don't talk about it. When you started, you had said something about silos, and I think Kathleen kind of addressed that a little bit in the interdisciplinary. I was just wondering, how you,
Yeah.
what you envision in your day-to-day palliative care, because this is something that I personally feel that physicians have a perspective, nurses have a perspective, and that we should truly be a team because we have different perspectives and different experiences and different education. Do you have any comment on that?
Yeah, I mean, I think a lot of times, unfortunately, it comes down to time. And when you're in the hospital, it's like you have to go see the next person and you don't communicate as well as like one should. And I don't want to stand up here and say you should always talk to the nurses, but so like I think that is the answer, right? Like I don't think it's any more complicated. I think it's that 30 seconds after the family meeting that you go back and say what happened in the family meeting that impacts things. I think when I talked before, when I was a bedside nurse, I didn't know that physicians emailed about patients. I like had no idea that was a thing. So there was all this buildup to family meetings, and I would just come in every day and be like, I can't believe nobody's doing anything about this. And then on the third day, somebody would be like, oh, we've been emailing for 2 weeks about this. And I'd be like, how was I supposed to, like, so you have this moral distress that builds and builds and builds, and you just don't know that other people are communicating about it as well. So I do actually think that the solution is just as simple as communicating, which is a frustrating and easy answer.
Thank you.
Any questions from Dana-Farber? Hello? Any other questions? All right.
Thank you.
Thank you so much, Kate.